Good morning, everyone, and thank you for attending our webinar this morning, The Integration of Opioid and Suicide Identification, Prevention, and Care, a National Perspective. This is presented by the ATTC network. We are funded by the Substance Abuse and Mental Health Services Administration, and we are a part of the ATTC network, which is celebrating 25 plus years in behavioral health workforce. The MHTTC is also funded by SAMHSA and is modeled on the ATTC. We have the Great Lakes region, which is Region 5, and we serve Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. The Central East also serves Delaware, DC, Maryland, Pennsylvania, Virginia, and West Virginia. This webinar will be recorded. Recording and PowerPoint slides will be available online, and there are no CEUs offered for this webinar. Today's audio will be broadcast through your computer speakers, so please make sure they are turned on and up. There is no call-in available, so please use the chat or questions feature below the slides to ask any questions, and we will have a Q&A session after the presentation as time allows. Today's first presenter is Dr. Jane Pearson. Dr. Pearson is the Special Advisor to the Director of the National Institute of Mental Health on Suicide Research. She chairs the NIMH Suicide Research Consortium and serves as the National Institutes of Health representative to the Department of Health and Human Services Federal Steering Group on Suicide Prevention. She assisted in the development of the Surgeon General's call to action to prevent suicide and the first national strategy for suicide prevention. Dr. Pearson also served as a member of the Veterans Administration's Blue Ribbon Work Group on Suicide Prevention and currently staffs the National Action Alliance for Suicide Prevention Research Task Force. Dr. Pearson is an adjunct associate professor at Johns Hopkins University and a fellow of the American Psychological Association. She has a private practice in clinical psychology and has authored papers on the ethical and methodological challenges of suicide research. Welcome, Dr. Pearson.
Can everybody hear me? All right. I think we're rolling. So I'm assuming the whole audience knows what OUD means in terms of opioid use disorder, but my clearance folks said make sure everybody knows. So here we go. I guess there are no CEUs, but we are also asked to do this. So here's what I'm going to cover today. I'll just do an overview of some of the national trends. I'll try to look for the subgroups, and this has been a challenge for a number of us at the federal level, and I'm sure it is at the state level, to figure out where to allocate resources and some possible reasons for some of these subgroup trends. And then even though Richard McKeon will be talking about some of the intervention work, I will also mention a few things happening at NIH. So in September, which is Suicide Prevention Month, our director, Josh Gordon, wrote a joint blog with Dr. Nora Volkow at the National Institute of Drug Abuse describing this overlap. And they described what they felt was possibly a pretty high overlap between these two disorders. You can read it off of our NIMH website. But they basically pointed to challenges, and I'll go over this shortly, in terms of making decisions about manner of death and intent, and of course some of the risk factors that you all are dealing with on a day-to-day basis. What I'm going to refer to for a number of slides here is this report, Pain in the Nation, and that came out in 2017, the first version of it. It was developed by a number of foundations, the Trust for America's Health, the Wellbeing Trust, and the Robert Wood Johnson Foundation. So the first report came out in 2017, and actually 2017 was the third year in a row that overall U.S. life expectancy had decreased. And so this was, in the news. I'm sure you've heard deaths of despair, diseases of despair. And they updated some of the information from that 2017 report in this 2019 brief. And there's the web link for it if you want to take a look. So this is from a brief from the CDC directly, showing the increase in suicide since 1999 up to 2017. This goes up to the, as I mentioned, 2017 data. We're expecting to see the 2018 data, and we are not expecting to see it level off, unfortunately. So we all have a lot to do. So from the Back to That Pain in the Nation report, so suicide rates, this is an interesting graph just because it allowed a comparison of different demographic groups. So you can see the overall to the left, the dark navy, and you can see the rates by gender. This is from 2008 to 2017, not the CDC slide went back to 1999. This has some racial ethnic groups, not all on there, some age groups where you can see the percent change for the younger folks up to age 17 going higher, although those numbers themselves are small. The percent change was huge. Increases basically across the board. And also, I'm sure, as many of you are aware, higher rates in rural areas, or a higher percent change in rural areas. This is also from the Pain in the Nation report. So these are counts. These are numbers of deaths. Now this is back to 1999 going up to 2017. The blue line on the top is adding them, all these selected causes of death over time. So the alcohol-related deaths can be pulled out of CDC causes. The drug generally, so this would not be just opioids, but any type of drug deaths, drug-associated, and suicides. So the trend is going up for all of them in the last couple of years. And again, this is not news to all of you, but you can see how rapidly some of this started taking off, particularly around the drug deaths. The suicide deaths just have been creeping up, 1% or so for a couple decades. And again, I'm sure you all experience this, so you don't really need the map, but it is quite striking looking across the U.S. If you look at the left side, these are the rates of death, so how many deaths per 100,000 back in 1999 by state. And the darker the green, the smaller the number, sort of like a heat map, and the more it turns yellow to orange to red, the higher the rates. So on the right, you have 2017 data, and you can certainly see, if you wanted to call them hotspots, I guess, West Virginia certainly having a lot of, a big increase in rates, and New Mexico, New Hampshire, Alaska. And then part of what happened, of course, is, again, this is not news to you all, but with the shift in the opioid addiction moving to fentanyl and other synthetic opioids, they're certainly more lethal. And so you run into this huge jump in mortality with use, not just people being able to recover from an overdose, but just very highly lethal substances that people are accessing. So what are some of the reasons that people think there's this overlap and combination? Because, of course, it's important to understand for prevention treatment, and trying to get a handle on this, basically. So there was a very interesting article in New England Journal of Medicine by Amy Bonnert and Dan Elgin. And these folks work at the VA and have access to a lot of VA data that they've been looking at, but they're also very knowledgeable across the field looking at larger data sets. So I'm sure some of these factors have been entertained by yourselves already, and it will be interesting to see if people have questions or comments about this in the chat box. But one issue, and this is kind of like the beginning of the opioid problem, was the pain ratings, the fifth, what's it called? You guys know, where everybody's asking about pain for every visit, basically, essential sign or whatever it's called. So if people have any pain, is this now related to the increase in opioids? Yes, we know that happened. But how would that be related to suicide risk? Well, perhaps chronic pain is related to suicide risk directly as well. And yes, you can find data that shows those three things all co-occurring. The second bullet here, in terms of, are there just more opioids available for both the fatal and non-fatal overdose events? That's definitely true, and Bonnert and Elgin would argue that's where the strongest evidence is. If you decrease the availability of this, you can see both of those go down. And they point to some work in other countries around that. The case in Deaton, deaths of despair approach that was focused more on social factors and patterns, there's certainly a correlation there. But whether it's the sole driver, Bonnert and Elgin kind of question the potency of that argument. Shared risk factors, absolutely yes, and that's why we're having this webinar. We do know that mental disorders, substance use disorders co-occur, and there's going to be some of those co-occurrences more so than others in different demographic groups, and those in combination we know increase risk for suicide. The intent to die or not to die is really an interesting question, and it has implications for how these different categories are counted in terms of was this a suicide death? Was it intentional? Was it an accidental death? This overdose happened without the intent to die. And the challenge here is that it's just not so simple a yes or no, even though the coroners and medical examiners are asked to do this. It's almost an impossible job. It's probably a challenge to figure out how this all works, and I'll show you a little bit of data and how this has been approached by others. And then the question is, what happens if you treat, for example, suicide ideation? Are you decreasing the risk for opioid use disorder, or vice versa? And from my perspective, we don't have a lot of data showing one or the other. We think it's probably important to treat both at the same time. You probably have to decide as clinicians how to take this on. But we don't have a lot of data saying if you reduce one by treatment, the other one goes away. We actually do have some interesting early prevention work with youth that would suggest if you're able to reduce first use, misuse in young people around substance abuse problems, you probably are going to reduce a risk for suicide ideation and behavior. But how it's relating to the opioid epidemic right now, we don't have a lot of good direct data on that. And I just wanted to walk through this one a little bit. This is work by Ian Rockett, Eric Kane, and their colleagues, where they've taken on this whole issue of how do we look at these types of deaths without being kind of stuck on the manner of death or how the coroners and medical examiners have to make these decisions, because there's so much overlap. So they have developed a series of articles. They've developed some pretty persuasive arguments that when suicides are considered, we know they're undercounted. I'm sorry if I hear crackling. I hope you guys aren't. I don't know if it's my phone. when suicides are undercounted, which we know they are, they're actually undercounted in certain subgroups. So they have concerns about who that might be, and I'll get back to this on this slide in a moment. They know medical examiners and coroners have limited resources to really kind of go in depth to understand people's experience before they die, to understand their suicide risk. They know that there's going to be variability across MEs and coroners, medical examiners and coroners, and we know this because when a medical examiner might change in a state, the rates for intentional and accidental deaths can shift quite quickly. So, you know, there's the human factor in this in terms of the judgment, and they feel like there's perhaps a way of looking across those categories that would be more useful. So they've come up with this term called self-injury mortality, which basically means you're engaging in some act that results in mortality, intentional or not. So let's see. Do we need to do something about the audio? It sounds like it's getting worse.
Hi, Jane. I'm sorry. This is Ann. We're just going to pause for a minute, see if we can fix the issue with the audio, and we'll be right back.
Hey everyone, I just paused the audio, and when we've had this issue before, is anyone using a mobile phone?
I'm not.
Okay. It seems like our audio issue has stopped now.
Excellent.
Yeah. Should we give it another try?
I'll plow ahead and see
I
if
will resume.
hopefully we'll.
Okay, I'll resume
Okay.
the audio.
Okay, am I back on now? Okay, I hope so. All right, so this self-injury mortality approach starts looking at deaths by intentional, so suicidal deaths, as well as non-intentional. And there's ways of clustering these types of deaths by considering different substance uses that people have had. And these authors felt like it was important to look at this, particularly for some subgroups. And as you all know, more men die by suicide than women. But if you start looking at this by combining the substance abuse categories, alcohol deaths, substance abuse deaths, and then start looking at male to female ratios, this graph shows that there are the male to female ratio isn't as dramatic for this kind of category, the self-injury mortality, as it is for suicide. So you begin to see these subgroups at risk if you think across those types of deaths, accidental and suicide, particularly around substance use problems. So the graph just tries to illustrate how the mortality rate for women, black women in particular, is much higher than if you can combine the substance abuse with suicide than you might not see otherwise, which has a lot of implications, of course, for outreach, prevention, and treatment. Oh, sorry, there's translation problem here on the slide a bit. So again, this is from, the map on the right is from a publication in 2015 about buprenorphine providers, and I'm sure there's a different map that's probably available now. I couldn't find one. But it just shows where we certainly need more providers. And if you think about the prior maps on states where we had the most challenges, we know that there's going to be this overlap in opioid problems, mental health problems, and a lack of providers. And I'll just move on since this is kind of a messed up slide. This is from SAMHSA's National Household of the Survey on Household Use of Drugs. Sorry, I need to have my, there we go. Okay, National Survey of Drug Use and Health. I'll get it out there yet. And this is the overlap for people responding in the survey around their report of having a serious mental illness along with their history of misuse of opioids over the past 12 months. And we clearly know there's that overlap area. And these are more graphs from the NISDA. And the solid graph, the boxes, you can look at in the middle of the different age groups that are plotted here from 2008 to 2018. And when the box is solid, it means it's different from the 2018 group. So it's trying to illustrate where there's been a significant change. So in this case, it's the 18 to 25-year-olds reporting higher suicide attempts over time. So this is like a backdrop to the opioid problem. And this is showing that we've got a cohort of 18-year-olds and probably even younger kids when we look at YRBS with higher rates of attempt coming through the population going forward. These are the trends in the opioid use disorder. So again, if we look at the blue box, these are the 18 to 25-year-olds, we see, fortunately, a decrease. It's not saying anything about the other substances that we might be challenged by, but at least we've got a way of mapping these different trends. And I just wanted to make sure you were aware of those and actually were aware of national reports. And then I'm just going to mention quickly before I hand it over to Richard that there is an initiative at the NIH called HEAL, Helping to End Addiction Long Term. And let's see, I don't know if the bottom is going to show, maybe not. So what NIMH has done, recognizing that there is this overlap in mental health problems and substance abuse, is to issue an RFA where, it was broken up, where we were soliciting applications that would use a collaborative care model, one way of integrating mental health with substance abuse and general health care into one model, and work with primary care providers to do a better job with screening, brief interventions, referrals as needed. And so these were just recently funded. There's 4 studies, and they are covering these areas. So perhaps, since a number of you are from these areas, you may, I don't have a list of all the project office, or the primary investigators, but it's a start in terms of thinking through how more of a system-wide collaborative care approach might be able to address all this comorbidity. And actually, I will just keep going and hand it over to Richard. I think his slide will show up if somebody hands it to him. So thank you for listening, and I look forward to your questions.
Thank you very much, Dr. Pearson. That was really good information. We are going to move on to Dr. Richard McKeon. Dr. McKeon received his PhD in clinical psychology from the University of Arizona and a Master's of Public Health in Health Administration from Columbia University. He is currently Chief of the Suicide Prevention Branch in the Center for Mental Health Services of SAMHSA, where he oversees all branches of suicide prevention activities, including the Garrett Lee Smith State Tribal Youth Suicide Prevention and Campus Suicide Prevention Grant Programs, the National Suicide Prevention Lifeline, the Suicide Prevention Resource Center, and the Native Connections Program. He has served on the National Action Alliance for Suicide Prevention Task Force that revised the national strategy for suicide prevention and participated in the development of WHO's World Suicide Prevention Report. He is also co-chair of the Federal Working Group on Suicide Prevention. Welcome, Dr. McKeon, and we look forward to your presentation.
Thank you very much. I'm pleased to be here with you, and also pleased to hear Jane Pearson's informative first presentation on this topic. What I will do is I will probably skip over a couple of slides that may duplicate some of what Jane has presented. And so if you'll bear with me a little bit about that. And this is the standard disclaimer saying the views, opinions, and content do not necessarily reflect the opinion of SAMHSA. So if I say something that you don't like, blame me, don't blame SAMHSA. And, this is just to underscore some of the data that, that Jane talked about. The great concern about suicide rising across the United States. Last year, the CDC in their vital signs report showed that suicide was rising in 49 of the 50 states, and they titled it More Than a Mental Health Concern. And part of that was that they were referring to that only about 50% had a diagnosed mental health problem, but that didn't include substance abuse. And if you included that in, that added another 25 to 30% there. And of course, we know when both conditions exist together, the risk is just increased. And so, this slide shows the increases by state. Nevada was the only state that had a decrease, but we cannot, we cannot take too much comfort from that because Nevada has historically had one of the nation's highest suicide rates to begin with, although it did decrease by 1% during the period from 1999 to 2016. But unfortunately, we've been going in the wrong direction, even as we've tried to ramp up our suicide prevention efforts. The suicide is now the second leading cause of death from age 10 to age 39. It's pretty remarkable when you think of it. And then it drops as a leading cause of death in people in their 40s or their 50s. But that's not because the number of suicides are going down or that the rate is going down. It's because other causes of death, such as heart disease and cancer, are starting to escalate at an even quicker pace. It's also, I think, important to recognize that the opioid overdose deaths and suicide deaths in 2017 were virtually equivalent to 47,100 suicides, 47,700 opioid overdose deaths. Now, the opioid overdose deaths were part of a still larger pattern of all overdose deaths, which reached to 70 million. But all of these deaths, what Case and Deaton have called the deaths of despair, clearly require intense focus and efforts at treatment and prevention. So Jane mentioned NISDA, the National Survey on Drug Use and Health, and this is a powerful scientific survey that it's a household survey in many thousands of households across the country, representative samples, and it enables us to generate estimates of a variety of different issues. But starting in 2008, we were able to make estimates around suicidal thoughts and behaviors. And what you see here on this slide is that the number of adults, and this was from year 2017, 2018 is now available, but in 2017, 10.6 million American adults had serious thoughts of committing suicide. That's not any suicidal ideation. That's what people would describe as serious thoughts of ending their life. And that's only 18 and over. So it doesn't include younger teenagers who might have suicidal thoughts. And Jane showed you some of the concern in that age group where suicide has been increasing. You can also see that 3.2 million made suicide plans and 1.4 million attempted suicide. And again, this is adults age 18 and over. And I think this actually is the exact same slide that Jane showed you. But again, it particularly shows the escalation around age 18 to 25, the young adult, where suicide attempts have been increasing. And while the numbers for suicide deaths are greater among older Americans in midlife, the baby boom generation having the largest numbers of people, suicide attempts are actually more common among younger people, and it's escalating in this, as this slide shows. And the same thing is true of suicide plans and attempts. So what you see is ideation plans and attempts following the same pattern of increasing, particularly among young people. So this is actually a slide from NIMH, which looking at, and this was, I think, 2016 data, where some of the deaths and attempts might be seen or might have had contact with. And you'll see things under in the oval listing annual suicide decedents. You can see about that within 30 days of death, about 20,000 people had accessed health care, and over 20,000 had been seen in an emergency department for any reason in the past year, really highlighting the importance of strengthening suicide prevention within our healthcare systems. And then when you look at annual attempts, look under SU treatment or substance use treatment, an estimated 110,000 suicide attempts among those receiving annually, among those receiving substance use treatment. Again, showing the close links and the importance for strengthening more collaborative efforts. There's also data that on substance use and suicide that's come from CDC's National Violent Death Reporting System. They have found that about 22% of the suicides involve alcohol intoxication, and maybe 30 to 40% of suicide attempts do. Their data indicated that opiates, including heroin and prescription painkillers, are present in 20% of U.S. suicide deaths. Marijuana in 10%, cocaine 4%, amphetamines 3%. So a couple of other things in terms of the relationship between suicide and substance use. That substance abuse is second only to mood disorders in its association with suicide, and comorbidity increases that risk even further. We know, because alcohol has been studied much more closely than any other substance, we know that suicide mortality can be impacted by changes in alcohol control policy. For example, when the drinking age in the United States was increased from 18 to 21, this was associated with decreased suicide mortality, estimating about 600 lives saved annually. This slide comes from our colleague Eric Kane at the University of Rochester, who Jane mentioned earlier, talking about common risk factors for premature death. And I think this is extremely important, that many times there are these shared risk factors that lead to increased risk, but that increased risk can end up being expressed in a number of different tragic ways, including suicide, motor vehicle accidents, and accidental overdose deaths, and also things like legal system involvement, emergency room visits. This also gives us hope, though, that by intervening early on some of these levels, we may be able to examine preventative strategies that could help with both. An example of that would be there's some promising work on the good behavior game for first and second graders, which had a positive impact in adolescence. There's also some more recent work coming out of Montreal showing how a combination of screening and intervention may be able to help with both as well. Now, one of SAMHSA's major efforts to prevent suicide is our Garrett Lee Smith Youth Suicide Prevention Grants. These grants go to every state as well as to many tribes. We have encouraged for work to take place across the full range of youth-serving systems. So not only mental health systems, but also emergency rooms, substance abuse treatment programs, working together with substance abuse prevention programs, juvenile justice settings, foster care, etc. And we've looked at suicide mortality and found that counties that were implementing activities funded by these grants had lower rates of youth suicide than matched counties who did not. But the impact did fade. This was our first study. We have done a second study that was just published that shows that the impact is now able to be sustained for 2 years, and that it's directly related to the years of continued funding, which is important. Basically, the bottom line is that suicide prevention is not a one-and-done activity. It has to be continued. It has to be sustained over time. Another major effort that SAMHSA, as well as other federal agencies, has been engaged in supporting is called Zero Suicide. And this comes out of work that was done at the Henry Ford Healthcare System, and this work was incorporated into the U.S. National Strategy for Suicide Prevention. Basically, the idea is to try to strengthen suicide prevention within a variety of different healthcare systems to be able to provide safer suicide care. And these are the major components of Zero Suicide. That leadership buy-in, the idea that that all of the staff should be trained in suicide prevention. I often tell the story that when I was in graduate school, the only suicide prevention lecture that I heard in 4 years of graduate training and 1 year of predoctoral internship, the only one that I heard was one that I gave, because a psychopathology professor said pick a topic and present to the class. So I picked suicide prevention and presented on that, and that was it, literally. Sometimes people also ask, is there a relationship? Can you show that having people trained leads to reductions in suicide? And the answer to that is yes. The Weiladol study in England showed that there were a handful of factors associated with reducing suicide in health and mental health care systems in England. And one of those was the clinical staff being trained at least once every 3 years. Identification is another important area. And so a lot of effort has been going on into screening using things like the Patient Health Questionnaire 9 and the Columbia Suicide Severity Rating Scale. And then of course, for years within substance abuse, SBIRT has been used, the idea of screening, brief intervention, and referral, as a model. So there's a need to have more work done about engaging the efforts in terms of screening and risk identification in suicide and substance abuse, rather than have them continue on really parallel tracks when they have so much in common. And then treatment, there are now multiple randomized controlled trials showing that if you focus directly on suicide as an issue, you can reduce the amount of suicidal behaviors. And then there is also work that is going on integrated substance abuse and substance abuse treatment models. Christy Sanders Esposito at George Mason in Virginia is doing work of that nature around adolescence. Transitions refers to the fact that we lose people in the United States every day who have left inpatient units or emergency departments, but don't connect to ongoing care. It's a very high-risk time period, and our systems need to get better. And I think this just underscores it when you look at the issue of non-fatal opioid overdoses being seen in the emergency room, and the need for stronger emergency department-based interventions. And then finally, the idea that all of this needs to be part of a continuous quality improvement loop. There's no simple formula for suicide prevention, so we must be continually working to improve. The thing I would mention is that in these zero suicide grants that SAMHSA gives out, one went to the state of Iowa, who's now involved in implementing zero suicide across substance abuse treatment programs across the state. So sometimes the name zero suicide has been controversial, thinking that it means that it's somebody's to blame or at fault if a person's life is lost while under care. And that's not at all that. We know that a clinician can do everything right and still potentially lose someone to suicide. But the importance of the name, I think, is summarized by this quote. When you design for zero, you surface different ideas and approaches that if you're only designing for 90% may not materialize. It's about purposefully aiming for a higher level of performance. So it's about not accepting the status quo in suicide prevention and healthcare. It's about aiming for a higher level of performance with more cooperation across an entire system, less reliance on single clinicians to do some of the most difficult things in healthcare. The Joint Commission has increased their focus on suicide prevention. They recently issued a revised national patient safety goal for suicide. I'm not going to go over that in detail in the interest of time. And so, to summarize, what's different about zero suicide is that it accepts a core responsibility of healthcare as being suicide prevention, to not accept patient deaths by suicide as inevitable, to emphasize data, best practices, and continuous improvement, and a systematic clinical approach. Again, Henry Ford showed it was possible to dramatically reduce suicide deaths in your healthcare system. And this is a graphic that just shows you the key components that we have talked about. This is a resource from SAMHSA, Assessing and Managing Suicide Risk, and it is currently being revised by the Suicide Prevention Resource Center specifically for substance abuse treatment. And this has been out for a while from the Center for Substance Abuse Treatment at SAMHSA, Tip 50, Addressing Suicidal Thoughts and Behaviors in Substance Abuse Treatment. This is a resource that you can order online from the SAMHSA store. It's called the Suicide Assessment 5-Step Evaluation Triage. It walks you through doing a suicide risk assessment. And we have also made it into an app, which can be downloaded from either the Apple or Android stores. And just a little bit more about emergency departments, and then I'll be closing up. The ED SAFE study, which the NIMH sponsored, showed reductions in suicidal behavior for suicidal people discharged from emergency departments who received telephonic follow-up. Using a face-to-face follow-up, the White Mountain Apache tribe in White River, Arizona, achieved almost a 40% reduction in suicides among youth. The VA, in a study called Safe Vet, found that safety planning in the emergency room combined with telephonic follow-up led to a 50% reduction in suicidal behavior and twice as many veterans connecting to outpatient behavioral health care. And SAMHSA's evaluation studies have showed that almost 90% of suicidal callers report that follow-up phone calls help them stay safe and not kill themselves. So I mentioned to you the National Suicide Prevention Lifeline, so you're aware that that exists, 1-800-273-TALK. It's available 24 hours of the day, 7 days a week. Over 2 million calls were answered in 2018. And I'm going to end with this slide, which just looks at some of the critical issues on suicide and opioids. Jane's already talked about the issues around classification and what are suicides versus what are accidental. And the reality is that sometimes you can talk to somebody who's made a non-fatal overdose and they may not even be clear themselves on what their intent is. So for some deaths, it may not be possible to determine. But whether intentional or not, they may require similar responses: medical care for the overdose, assessment for suicide risk and substance abuse, and rapid follow-up. And then we need to find ways to integrate suicide screening and substance abuse screening, how to integrate suicide care into substance abuse treatment, as the state of Iowa is now trying to do, how we can assist communities that have been heavily impacted by both suicide and opioids, looking more closely at the impact of chronic and acute pain, and how can we alter the developmental trajectories that lead to both types of tragic outcomes. So with that, let me stop, and thank you for your time and attention.
Thank you very much, Dr. McKeon. Jean Pulvermacher is going to go over some of our resources, and if you have any other questions, please add them to the chat box, and we will be answering questions in the last 10 minutes we have left.
Good, thank you, Anne. Hi, everyone. My name's Jean Pulvermacher, and I'm the co-director of the Great Lakes ATTC. Thank you, Dr. Pearson and Dr. McKeon. Fabulous webinar series. I just want to take a couple minutes here to go over some resources that we have. We have some national resources we can share with you, and then also some regional specific. So first, I want to talk about Suicide Prevention Resource Center. They're funded by SAMHSA, and they're the only federally supported resource center devoted to advancing the implementation of the National Strategy for Suicide Prevention. And Dr. McKeon talked about the Zero Suicide product that they have. But just a couple of highlights from the SPRC website. They have information on the intersection of opioids and suicide. The scope of the problem section offers key data points and slides that you can download. There's also information on a public health approach to suicide prevention. It's the effective prevention model, outlines a public health approach to suicide prevention in its 3 components. There's some collaboration resources, substance abuse and suicide prevention collaboration continuum. It offers tools, examples, and resources on building collaborative efforts across the 2 fields, and also partnerships virtual learning lab that has worksheets, resources, and strategies for overcoming common barriers in collaborating with partners. And then finally, the suicide prevention resources for clinical settings. The Zero Suicide Toolkit provides descriptions, citations, tools, and examples of the 7 core elements for a comprehensive approach to transforming suicide care and health systems. A new version of the toolkit for Indigenous populations was released earlier this month. And the Suicide Use Disorders and Suicide Framework, the webinar on improving suicide care for patients with substance use disorders is available. Check out their website for more information. I also want to share some resources from the Central East and the Great Lakes ATTC and MHTTCs. We have lots of resources that are available on our website. All the resources are available in our products and resources catalogs on our websites, and they're updated continuously with new resources, as well as a handout with links to these resources can be downloaded from the file SharePod today. First, I just want to talk about the Central East ATTC and MHTTC. They have an upcoming webinar in February that will talk about new research findings. There's trends of suicidal behaviors among high school students in the U.S., and it's called Even One is Too Many, Preventing Suicide Among Black American Boys and Girls. So check out their products and resources catalog and their website for more information on that. And then finally, the Great Lakes ATTC and MHTTC, you can visit our products and resources catalog for information, but we have some information that you can use. The Great Lakes Mental Health Technology Transfer Center Suicide Prevention Guide. It provides local and state-specific resources for school personnel in the Great Lakes region. The resources in this guide highlight intervention services available for immediate support. All states, again, have access to the 24/7 free confidential support via telephone and text, and many areas have mobile crisis response units available for immediate and in-person assessment and intervention. And then also we just want to highlight the webinar series, Suicide Prevention in Schools. It's 3 parts. Schools play an important role in recognizing and responding to suicide risk in students, and effective strategies must be embedded within a positive school climate that engages the entire school community. And you can access the recorded webinars from our products and resources catalog. So again, we just wanted to share some national resources that we have, and then also some regional specific with the Central East region and the Great Lakes region. And I think that's all I have. Thank you.
Thank you, Jean. Those are really good resources. We have a handful of questions that I just wanted to present to Dr. Pearson or Dr. McKeon, and either of you can answer. The first one I think was directed specifically for Dr. McKeon. And somebody asked what the blue circle in one of your slides was, and someone else commented that they thought the circle was the 10.4 million who had serious thoughts of suicide but no plans. Is that correct?
I think the 10.4 would include all those who reported seriously considering suicide. So that would include both those who reported having made a plan as well as those who did not.
Great. Thank you for that. Another question that we have is, do we think that safety planning reduces suicide and OUD for either of you?
I can jump in first, and then Richard should join in. So through that HEAL initiative, we were able to supplement some of our suicide prevention studies and ask them, can you take a look at what it's like, for example, in how is zero suicide being implemented? And Richard mentioned this, like a lot of people are trying to figure out workflows. Do you screen for everything all at the same time, and then you have to make a decision about what you're addressing first and so on? We also supplemented a study that's looking at individuals released from jail and prison. They might be waiting for a trial. They might be, waiting for all kinds of reasons, but they've been held in jail or prison for a while and then released. And if they've been using substances, of course, they're at high risk for relapse at that point. And if they're going back to their environments where this high-risk behavior was happening, it makes it very difficult. Those folks are getting safety plans for suicide prevention, and we ask them to talk to the folks being released to see how they look at the plan that they've developed, their safety plan, and how it's affecting them. And it's not analyzed yet, but some of the reports we're hearing is that these people are released into very difficult environments. So if they're not under treatment, I would see the safety plan developed more as a relapse prevention, where you've probably made an attempt, you've gotten some treatment, and you've developed some skills that you're going to try to hold on and anticipate relapse prevention. But there's still a lot we have to learn about this and see how it works. So, I would just say stay tuned. But if for those of you who understand safety planning, it is a way to develop kind of a safety net for somebody. I don't know how long, they can keep it intact. Depends on how they use it and who they reach out to. But for most patients, and I would say providers, clients and providers, it has a lot of face validity, and it is definitely worth trying. So, Richard, I don't know if you want to add to that.
Yeah, I'll just add a couple of things. For many years, the intervention that was typically used by mental health clinicians were called no suicide contracts. And not only was there no evidence for their effectiveness, but there was evidence that in some instances they were harmful. The difference with collaborative safety planning is that there is a focus on working together with the patient about what they can do, not to just make them promise what they won't do. And safety planning is a relatively short intervention, that can be taught and can be implemented and utilized in a variety of different settings. So it's not as complex as, for example, something like dialectical behavior therapy in terms of the required training, or cognitive behavior therapy. So it's a very important advance that we now have research showing its impact, and it makes sense that it would be that it could be applied regarding for opioid use disorder as well, but I'm just not familiar with examples of that research going on. I wouldn't be surprised if it was, but I'm just not aware of any.
Thank you. The next question says, do you have any examples of how opioid fatality review boards may be looking at the overlap between opioids and suicide?
I'm not. I'm aware of that. That there are. Go ahead, Jane.
I was just going to say, I don't know the opioid fatality review boards, and it sounds like a great opportunity to look at this question. So whoever asked it, if you keep asking the question, we need that information.
Yeah, I think that, the one or two examples that I'm aware of, we're not looking at suicide. We're only looking at opioid doses. And of course, looking at suicide deaths as part of a review process like that, although for youth suicide reviews take place in upwards of 40 states in the U.S., very few states, Montana was the first, look at all adult suicides as part of a review process. So if the questioner learns of any, let us know. Let me jump ahead, if I could, to the question after that, which says, are there examples of ED follow-up programs that combine follow-up for suicide attempt or overdose? I've heard of one or the other, but not both combined. I'm in the same boat. I've heard, but I think that they can be combined. I do know of one effort in West Virginia where they were looking at doing that kind of follow-up, but I've not heard any reports about how that's been going. Barry Fawcett in West Virginia was the contact person who's been involved in West Virginia suicide prevention efforts for a while, who was engaged in that. But that's the only example that I'm familiar with.
Great, thank you. We just have about 1 minute left, and I just wanted to take a minute to remind participants that we will have additional webinars highlighting some of the research that Dr. Pearson is familiar with. And if you want to check on our Great Lakes Mental Health Technology Transfer Center websites, you should be able to see when those will happen. I want to thank both of our presenters today. We really appreciate all of the information. Again, the slides and the recordings will be available on the websites. Later today or first thing tomorrow morning, all of the participants will get a survey, and we would truly appreciate it if you could take a couple minutes and fill it out. Thank you.
Thank you.
Thanks for the opportunity.